Much. Okay, so my name's Rosie. I'm a University of Leeds graduate and currently an F1 working at Forth Valley Royal Hospital. It's outside of Glasgow, hence why I'm at work at the moment. I did my presentation and my essay on chronic pelvic pain and how effective the current diagnostic and treatment guidelines in the field of chronic pain are. And could you pop it to the next slide? Thank you. So just a brief introduction and structure. So one of the reasons I chose to do this was that I'd seen it a lot in my general practice rotations and often felt like there wasn't a clear sort of resource or guidance on how to go about diagnosing and managing chronic pelvic pain. And it led to lots and lots of sort of these follow-up appointments and some trial and error, which can be useful, but also quite drawn out processes before people were necessarily referred to specialists. So it was quite a big topic. So I'll go through a background on some of the definitions and how common it is and causes, diagnosis, management, and looking a bit about how effective these managements are. And I've broken it down into sort of pharmacological methods, surgical, and then sort of some of the broader psychological, social, and complementary therapies that maybe aren't so widely used, but sort of coming into play. Next slide, please. So as Royal College of Obstetrics and Gynecology, or the RCOG, define chronic pelvic pain as pain in the lower region of the abdomen or pelvis lasting greater than 6 months. It's very common, affects 1 in 6 women in the UK, according to one study. And again, it's a very common presenting complaint in general practice. And I've just put a little diagram here just to show that there's a lot of structures in the uterus, and often there's more than one cause that can be contributing to chronic pelvic pain. So this could be part of the uterus, the bowel, bladder, pelvic muscles, but also coming into play these sort of psychological, social issues and certain risk factors that can predispose people to experiencing chronic pelvic pain. There's a huge range of effects on quality of life. It can have physical effects, it can affect how people do their jobs, it can have effects on sexual health and social and more mental factors as well. And next slide, please. Next slide, please. Oh, thanks. Perfect. So I just created this little table because there is a huge range of conditions, and some of the most common being endometriosis, IBS, adenomyosis. And this also shows quite a few of the crossovers of symptoms. So things like IBS can cause constipation, diarrhea, bloating, but things that can also cause these symptoms are endometriosis, pelvic congestion syndrome. Pelvic pain features in sort of all of these, but other things such as more defining features such as PV discharge and pelvic inflammatory disease, abnormal PV bleeding and endometriosis, and then considering other things that are in the pelvis area like MSK related pain, lower back pain, which can also cross over with things such as pelvic inflammatory disease. I think it's important when looking at this is taking this over into like diagnosis and management, not always looking for one underlying cause of chronic pelvic pain. There might be more than one cause, and when treating symptoms and condition and sort of the effects on quality of life, it's just understanding that there's quite a wide range of conditions that can play into it. Next slide, please. So the main set of guidelines are the RCOG Green Top guidelines, which set out a structure for diagnosis of chronic pelvic pain. Really important is the initial consultation with a thorough history and sufficient time to express symptoms and impact on quality of life. And it's really important that people feel listened to and that their concerns are being taken in as, a serious manner, as it can have quite a big impact on so many aspects of life. Examination, whether this is abdominal, pelvic, bedside tests such as swabs or speculum examination. And then ARCOG suggests that there should be quite an early referral to a specialist. Usually this will be a gynecology specialist for further assessment, diagnostic tests or scans, such as abdominal scans, transvaginal scans, or any other scans that might be deemed necessary, or further blood tests. Specific conditions, you might want to consider other diagnostic imaging, or for instance, at the moment, diagnostic laparoscopy is the gold standard for things such as endometriosis. However, it might be that treatment, as can be used as part of diagnosis, trials or treatment, which may improve symptoms and might remove the need for such invasive surgery. So next slide, please. So split management quite broadly into 3 categories, but there is a bit of an overlap, and often they won't be used in isolation. So that's medical and pharmacological interventions, surgical and psychological, social and complementary therapies. So next slide, please. So there's quite a few different pharmacological methods. Firstly, there's looking at symptom management for chronic pelvic pain, so things such as analgesia. This tends to be NSAID based, and there's some evidence suggests that this is usually the most useful form of analgesia. Oral contraceptives are commonly used for cyclical and dysmenorrhea type pain. These are often first line, but obviously there can be some contraindications. So things such as GnRH analogues can be used and are useful again when oral contraceptives maybe aren't tolerated. One study showed that women with chronic pelvic pain taking an oral contraceptive had 87.7% decrease in chronic pelvic pain compared to just a 12.1% decrease in pain in the group receiving over only NSAID therapy. And this was done using sort of pain scores and reports on function in day-to-day life. Medications can also be used for more specific symptoms, such as antispasmodics for IBS type symptoms, in conjunction with sort of dietary measures. Next slide, please. So the ARCOG and NICE guidelines have moved away from a more surgical approach, although it still can be useful in some situations. So ARCOG at the moment only really suggests surgical management for cyst aspiration and very large fiber adhesion fibers, but also considering that surgery has quite a lot of risk factors in itself, such as blood clots. Not everyone is suitable for surgery, and surgery in itself is a risk factor for more adhesions. So often surgery is not used in so much of the early stages of diagnosis and treatment of chronic pelvic pain. Laparoscopic uterine nerve ablation and LUNA, one double-blind trial showed improvement in dysmenorrhea only, which is only one aspect of chronic pelvic pain. So it might not be appropriate for all people experiencing chronic pelvic pain, and it wouldn't be perhaps so suitable for lots of other symptoms. Just touching upon hysterectomies, which there was one study, I think I meant to include it in here, that showed that it did show some positive results for some women, but I think it was 25% of women didn't actually have any improvement or had worsening in their pelvic pain. So importance of making sure that people are sort of risk factor stratified and considering whether long term this would be management, but obviously it's further down the line and has lots of implications for reproductive health and again further possibility of adhesions. Next slide, please. So this was a part of the essay I really enjoyed writing, psychological and complementary therapies. Really important, often overlooked, but there was a study that showed that up to 53% of women with chronic pelvic pain were found to have moderate to severe anxiety, and 26.7% experienced moderate to severe depression, which really shows the impacts of chronic pelvic pain on mental health, but how mental health can then impact into the way people experience pain. CBT is used by NICE for treatment of more generalized chronic pain syndromes such as fibromyalgia, but there is no specific chronic pelvic pain CBT guidelines, and there's minimal studies on the effects of CBT in the field of chronic pelvic pain. However, if we were to think about how it affects other chronic pain syndromes, it'd be really important to have some more research which looked into how chronic pelvic pain can be hopefully improved by CBT. So it's an area which could do with some more looking into. One really interesting trial showed that in a randomized controls trial comparing one group who did 8 weeks of yoga therapy versus 8 weeks of just NSAIDs alone for management of chronic pelvic pain, showed that there was a reduction in pain-related scores and there was greater relaxation achieved by those in the yoga therapy group. And when considering this as sort of perhaps not a sole management of chronic pelvic pain, but in conjunction with other methods, It's probably quite cost effective. It may not work for everyone's lifestyle, but it probably could be quite enjoyable and has shown to have some really positive results. So next slide, please. I'm so sorry. I've sent over the one that doesn't have the conclusion slide on, so I'll just read out the ones that I've got on my presentation that I meant to send over. So some of the conclusions that I came to during this essay was that it's really important to have an early referral to specialists for specific tests, and this can minimise distress during the diagnostic procedure and make sure people are gaining access to early management and treatment. Multifaceted treatments and managing both the condition with analgesia, medical or surgical intervention, whilst also making sure that psychological input is in place early on, particularly if people are having a big effect on quality of life. And further research is needed for chronic pelvic pain specific conditions, interventions, such as CBT. It'd be good to see if there's any improvement on sort of the symptoms itself, as well as any psychological sort of side effects of having the condition, and that holistic approaches are really important in order to improve long-term outcomes and quality of life, as well as treating each individual with chronic pelvic pain and their own impacts on their own day-to-day life. And so next slide, please. So there was supposed to be a question slide as well, but this is just some references. So if there's any questions, that's fantastic.